Can everybody hear me? Anybody want to move somewhere where you can't hear me? My name's Tony Davis. I'm the Commercial Director of the West Midlands Academic Health Science Network. I'd like to start off today by congratulating everyone for attending. It's an unusual way to start, but I feel that you've given us a level of intrepidity and commitment over and above the dreadful weather conditions that we're experiencing at the moment. Those of you who might know, we originally planned this meeting in December, and it got snowed off, and so we had a planning meeting, we had a long discussion about moving it, and it was agreed that the safest option was to move it to the 1st of March, because that was the start of spring, and there was no chance whatsoever that it would get snowed off. So please don't feel that you're cursed. I think it's just me and Neil that are cursed. But I hope you enjoy today. This is a really important event for us. We are, as some of you may know, heading into a period of being relicensed as an academic health science network for the next 5 years. And a key component of our national work, and the work that we've been asked to do by the Office of Biosciences, NHS England and NHS Improvement, a key factor within all that is digital and data. In fact, I don't think there is a single discussion with all of our commissioners that does not ever drift into the realms of what are we doing around digital health, what are we doing about health data. So with this in mind, we've been planning probably over the last 18 months for the launch of Digital Health West Midlands, of which this summit is an important part. We invited Will Smart, who is the CIO of NHS England, to come, and we cancelled the first meeting because he couldn't get here, and unfortunately, and realistically it is unfortunate, that he's going to come up from down south, and he didn't travel because it is quite perilous. But he's going to WebEx in. So if all the technology works, whenever you do a day like today, you can guarantee the technology will be a challenge. If all the technology works, I think it's 11:15, 10:15, we're going to be hearing from Will Smart. So that's really, really good. We've lost a couple of speakers as well, for the same reason. We're going to move the agenda forward a little bit. And that will allow for, and again, taking into consideration if the weather starts to turn bad, or some of you have got longer journeys to make. The hope is that we can get off a bit earlier so that we can avoid rush hour. So I've also been told there are no planned fire alarms for today. The closest toilet facilities are just on the other side of that big blue round building there. Is there anything else you need to know? Sorry, yes, I knew that there was something. As you can see, there is a gentleman there who is filming. If for any reasons that you don't want to be part of the filming and don't want your comments or your image to be used, please let him know, and he will make sure that we respect your wishes and think that it's out at the final film. So enjoy your day. I hope it's a fantastically constructive day. I hope you learn a lot, and I hope it's the first of many. I'm sure it will be, because you're going to be hearing from Neil and the team all of their plans, all of the exciting opportunities that are going to happen certainly over the next 12 to 24 months. So it's my pleasure to hand over to Neil Watson, who's going to take you through the day. Neil.
Thanks, David. You brave lot. Thank you. I've got just a few minutes before Will connects. The guys on the tech desk, as soon as you've got connection, just give me a wave and we'll So as Tony said, we are going to jiggle the agenda around. We expected some attrition rate, but I've got to say I'm pleasantly surprised by how many you did battle through the elephants and get here. And we, as well as having lost some speakers, of course, the panel Q&A without a panel. I'm not sure what you call that. But what we are going to try and do is some of the speakers later for the day, if they are here earlier, we'll try and fit those in. And one of the things we really want to do today is we're going to be sharing some information with you. We've got Will, who's going to be setting some of the context strategically about where the NHS wants to go with digital. But as an innovation agency, as an academic health science network, our strength is out there on those tables that you're sitting at. We deliver through our partners in health and social care, through our commercial and business partners, through our academic partners, through patients, citizens, and places who've got Health Watch represented. And we've devised Digital Health West Midlands based on what you've all been telling us is helpful and what works, and how you find you can interact effectively. Part of today is really about asking you how you want that to work. Whether you're a company struggling to get through that concrete door of the NHS, when you're frustrated that you've got technologies and solutions that can save lives and improve the working lives of our care professions, or you're an academic, or you're part of the NHS struggling to deliver the sort of health and care that we all really want, then we want to set up an environment in which you can really thrive. Your innovations and your ambition to innovate within the health system really can take wings and fly. So I do hope we've got a nice lunch, and the great news is there's going to be loads. And the plus side is, because of the temperature, I'm reliably informed that the additional calories that you burn to stay warm mean that you can just eat loads and loads guilt-free. So I hope you don't have to dash off after lunch. After lunch, we do have, the agenda goes on for a couple of presenters and some workshops. We're going to try and get as many of those presenters who can present before lunch to do so. And then we just want some relatively short table discussions to really pick your brains, steal your ideas and claim them as our own, so that we can devise Digital Health West Midlands as something that really delivers, first of all for our patients and citizens, but also for you, for our care professions and for the businesses and the employees in the region. So we're scheduled any minute now to be going to Will Smart, who, as Tony has said, is the Chief Information Officer for Health and Social Care for NHS England. So he's the top dog, and I'm really pleased that he's agreed to join us. We're still waiting for the connection. We've still got 3 minutes. But was it a man from Japan? No, I can't do that. So bear with us a couple of minutes while the technology starts. And if you could set your phones to mute, we appreciate it. But do please tweet away, spread the gospel. The hashtag is #WMHSN Digital Summit. If you haven't already, ping something out to the world and let them know what they'll be seeing. And some good pictures of the lunch would be really good. We regret that they couldn't go out because of a little bit of snow. I understand we've now managed to perhaps through to Will Smart. Will, are you able to hear us?
I can hear you.
Excellent. Perfectly well, thanks Will. I feel obliged to say hello London, this is Birmingham. But thanks very much for joining us, Will. I think we're just about to patch through to the screen so that we can see your WebEx display. And thanks so much for agreeing to do this. The weather's already cancelled the first iteration of this back in December, and we've been slightly doomed. But yes, we now have your slides on view, so I'll now hand over to Will Smart.
Good morning, and I'm very sorry that I can't be with you. Just to be clear, that I'm in snowbound Windsor, which there are many worse places to be snowbound in, it has to be said. So thank you for inviting me, and I am very sorry that I can't be there. I went to university in Birmingham, so it's always a real pleasure to get up and visit the city. I wanted to spend 15 or 20 minutes just talking a little bit about the national strategy, what we're focused on, what we're trying to achieve, and then spend a bit more time during that 20 minutes around local health and care exemplars to talk a little bit about what we want to do in data sharing and to give you a sense of what's happening next. If we have the time and opportunity, I'm very happy to take questions at the end. So, just to position me, my name is Will Smart, I'm Chief Information Officer for Health and Care in England, which is ironic coming from Northern Ireland, but I guess it's an opportunity for the Celtic fringe to take over. My role is to lead on the kind of technical strategy, on the IT strategy across health and social care. And there are 4 critical challenges I think that we're trying to address at this point. I've been in and around health and care for most of the last 25 years or so, and all through that time, health has been grappling with how do we actually use technology most effectively to help us deliver care to our patients and also to run our organisations most efficiently. We continue to struggle with that. We have the National Programme for IT, which I'm sure many of you will look back on fondly. We since then took a big step back and said, well, we'll just leave local organisations to get on with it. And then over the last couple of years, we've had PHC 2020 out of the National Information Board, which has been trying to work through a more nationally focused strategy with local autonomy. So through the GDEs, we hope to improve providers' digital maturity. Second area, which is where the local health and care records exemplars come in, where digital innovation hubs come in, is around how do we connect and integrate the health and care system. Health is very fragmented, as we all know, with nearly 300 secondary care organisations, over 7,000 primary care practices. Social care is equally fragmented, and the only way we can work as a system that really puts the patient at the heart is by connecting those up, and the only way we can do that is through data. Third area is around using data and information better. We talk a lot about artificial intelligence, we talk a lot about population health management. We know that we've got rich data sources. We also know there are many challenges with that data, but if we can only harness that data, make use of it, analyse it, understand it, I firmly believe we can improve the quality of the services we deliver and the efficiency of how we deliver them. And then finally, and I'm sure, I hope many of you have heard Juliette Bauer speak, but we have got Juliette's work around how do we transform the service through providing links to patients. So putting digital tools in the hands of citizens so that they can take more control of their own healthcare. And Juliette is doing fantastic work in that space. So if those are the challenges, we've drawn another picture which tries to express what we're trying to do. So we have created 5 pillars, and we've got a fallen over pillar, which I've been told I should describe as foundation. And we have a 6th foundation. And these basically address the 4 challenges that we talked about. So on the left-hand side, Juliette, empowering the person. So the work she's doing around NHS.uk, around 111 algorithms to support triage of patients, whether that's through the apps library and the developer ecosystem. We are very active in that space, and whilst we are a long way from where we want to be, that's an area that is accelerating, and we are really pleased with the work that HSNs and HIM are doing around supporting that work. Second area is around supporting the clinician. So how do we get digital tools into primary care and secondary care, support pharmacy and that kind of prescribing agenda. And you will have heard Jeremy Hunt last week talk about medication errors and his challenge to get electronic prescribing right through hospital. So how do we get control of the medicines agenda? And then finally, and most importantly, from my perspective, how do we give our workforce the skills that they need to actually use the tools that are now available to them? And I'm really pleased that we are about to start the first module of the Digital Academy with the first 101 English participants, so that's a great step forward. Third area then is how do we integrate services, which tries to focus beyond institutions towards pathways, so urgent emergency care, around elective care, around social care, but beginning to look beyond institutions to how can we manage data and how can we manage workflow across the pathways that patients tend to traverse, which is from their home and back to their home. As somebody who worked in secondary care most of his career, the world doesn't start and stop at the end of the doors of your acute hospital. Fourth area then is led by Tim Donahoe from Department of Health, which is actually that analytics agenda. So the data services platform, and Katie Farrington also from DH around cybersecurity, national opt-out, and that very important agenda around citizen trust in our use of data. We then have a fifth pillar, which has got CCIO at the top of it, who I'm sure you will all be aware is Dr. Simon Eccles. As we all know, every strategy is out of date as soon as you've written it. So this pillar represents our desire to keep looking forward, to see what's coming down the road in terms of genomics, in terms of innovations around cancer, informatics, etc., and make sure we've got a mechanism to move that from future into the programme. The second notable thing around that pillar is that there's no money attached to it. That is principally because I've always taken the view that you should never let CCIO have a budget because they will only squander it on useful things. So that's not to say it's not really important, and it's not to say that those are not areas that we're very focused on. Finally, the foundation layer is those services that NHS Digital provides, so the National Spine, NHS, the Spine architecture standards, e-referrals, electronic transfers, prescriptions, etc. So those things and those services that keep the NHS running on a day-to-day basis. So that's the programme, and that's how we are beginning to describe it. And I just want to talk about local healthcare records, and this is the next big thing that we are about to launch. I feel like I've been talking about it for the last 15 months, because I have been talking about it for the last 15 months, but we are now about to move into reality. So what we know is that we are increasingly talking about integrated care organisations. A few weeks ago we would have called them accountable care organisations, but the way that we need to organise within localities to support the delivery of care within communities rather than within institutions. And that requires the need for us to create infrastructure that can support organisations working together. The second key issue that we are really driving with these local healthcare records is the requirement to have learning healthcare systems, so areas that can innovate and can learn from that innovation, and most importantly can share that innovation with others. And I'm very pleased to always talk to academic health sciences networks because of the work that you do around innovation, importantly the work that you do around spreading that innovation, because that seems to me to be one of the biggest challenges that we have as a service, our great ability to reinvent every wheel multiple times over, the second endeavour to learn from the wheel that our next door neighbour has built before us. Third area is around using data to help us design care around the patient. And fourthly, that principle I touched on earlier, which is we want to support local delivery. I'm a firm believer that put the tools in the hands of the people closest to the problems, and they are the most likely to be able to resolve them. So local delivery with national facilitation, because we need to come up with a set of platforms that are able to work together. Therefore, there's a strong requirement for standards to be used. Those local health and care records will enable 5 uses of data, again, which I've talked about a lot over the last 12 months. The first is around giving clinicians access to an individual's care record across all parts of their care. The second is to support the care planning and coordination of care for that individual. The third area then moves us into secondary uses, where we will aim predominantly and as far as we possibly can to use anonymised data around population health management and planning. Fourthly, around evaluation, and also the kind of billing type processes, so the things that we need to do to operate as a viable system. And then finally, and very importantly, which LHCRs will pick up to some extent, but are very much being dealt with through the digital innovation hubs and the work of John Bell, Mark Walpole and Andrew Morris in the Office of Life Sciences, around digital innovation hubs, so environments in which researchers can be granted access to data to support innovation and development. And this is very much, we talk about it in terms of it being a reference library rather than a lending library. So researchers will bring their research to the data, they'll not take data to their research, and that there will be a lot of work happening on that, and I'll come back to that shortly. Important to say, and going back to my we like to reinvent every wheel at every opportunity, there are already over 60 localities that are already sharing data within their communities at different levels of maturity, but doing great work. And we want to make sure that we build on the best of the work that these localities have done, rather than thinking we now start from ground zero and build from nowhere. So one of the key parts of the work that we're about to do will be selecting 5 communities that actually have got experience in doing this, because that's the quickest way to get to the end point. So why do we need to do this? And again, I'm sure I'm teaching my various grannies in Birmingham to suck eggs around this, but we know that we have fragmented data sharing. Some of that is technological, and again, we will be taking a much firmer line with suppliers around them opening up their systems via standard APIs. Some of that is organisational and legal. We are constituted in a particular way within the NHS as individual sovereign organisations. That means data sharing falls within a set of legal frameworks that makes it bureaucratically, I'm going to use the word awkward, to share data, but not impossible. Again, I think 60 localities that are sharing data demonstrate that to be true. The third and probably most important challenge we have is a cultural challenge of trust and having the right systems, systematic approaches and systemic approaches to make sure that we can be confident that data is used properly. So we need to get into a place where there is a sense of data should be shared because it's the right thing to do, in the confidence that we can be transparent about how that data is used. We also know that sharing data does improve the quality and efficiency of care. So a couple of examples. In Hampshire, through the Hampshire Care Record, they've seen a 9% reduction in decision to admit to hospital because alternatives become available, or more knowledge about the individual. And in Cheshire, there's been in emergency care a 50% increase in same-day discharges from hospital. So we think there are real clinical benefits from doing this, and we believe that the evidence points to that. We also know, and I get many letters from localities, that as we move beyond direct care, it's really hard to get data to support planning within communities. And that data for operational planning is difficult to access. It's often not directly based on the care record, and there's often a significant timeline for it to be available. And if Matthew Swindells were here, he would, at this point, turn to the refrain of he knows what ED performance is 3 months after it's happened, and that's not a very useful way to understand what the system needs to do to improve performance. So we need to do something about making data available for service plan that's based on clinically what's actually happening and in near real time. So the local health and care records will see data shared for clinical purposes in real time, and it will be anonymised and made available for secondary uses as near to real time as we can manage. And then we need to use these healthcare records to be able to link to other tools and other data sets, whether that's genomics data or whether that is to algorithms through AI, and also make data available for research. So we have a huge level of ambition for the healthcare records. So the end point of this work will be initially in five localities with populations between 2 to 5 million, and over time nationally to a comprehensive normalised longitudinal care record. We thought we would use the snappiest title to describe it as possible, but importantly that record will sit across all venues of care within health and also social care, and we are also keen to begin to bring in other broader data sets like determinants of care, like housing conditions, etc., that could be useful in determining the most effective interventions within the system. So for professionals, professionals will have access to the data that they need to make the best decision when the patient is with them. And as a patient, importantly, we begin to enable the work that Juliette is working on by giving patients access to their records, giving patients the access to append to their records where appropriate. So, and then being able to create a safe environment for innovation to happen using that data which is freed up. So to encourage app developers and clinical entrepreneurs, etc., to really innovate and to really be able to develop apps that are able to integrate deeply into the health and care system. So the ability to use the data for depersonalised form for local planning, and then to create a set of interoperable records so that we can share data across localities. A real risk of where we are today is that we have 60 health and care records, all of which can only talk amongst themselves, and we need to move away from creating silos within silos. So what we are doing is over the next 2 to 3 months we will select 5 exemplar communities to create these local health and care records at a scale that we believe is sustainable, somewhere in the 3 to 5 million level of population. We're looking for localities that are already mature in doing this, and we are going to base our judgment of maturity on 2 kind of key areas, but clearly technical capability and maturity is important to us as well. But the first is around public and professional engagement. We believe the biggest challenge that we have is having the right conversation with citizens about their health data and how that health data can improve their own health, their own health care, but also the health and care of their families and of their communities. And we want to work with communities that have already started to have that dialogue. The second is we want to see evidence of there being a really clear link between the health and care records, of data sharing, and how those communities want to transform how they operate within their communities. So we don't want to create platforms that sit in splendid isolation, but ones that are deeply entrenched in the delivery of real-world solutions to real-world problems. We are going to try, and again, this will be local initiatives, but we need to create an environment where we continue to have national standards and national the ability for these platforms to connect to each other. So we will work with them nationally, we will blueprint and template what works, and that will then form the basis for how we extend these local health and care records out through the rest of the country. And to do that, we'll be creating a common design authority to make sure that we are designing standards in use and that we have a mechanism that enables those standards to be documented and deployed elsewhere. We'll be working with the IG network, professional reference groups and patients groups to make sure that we've got the right voices around the table. And a very strong message that's come back in the conversations that we've had around this is we need to be listening to the voices of those that aren't within the exemplar group of 5, and we are very aware of that. We will make sure that we do that. And then finally, we want to set up front our expectations of these communities. You cannot be called an exemplar without being exemplary, and that means that they need to be interoperable, they need to build that into their solutions, they need to adhere to IG. We're spending a lot of time, as you can imagine, talking about cybersecurity standards around these and how can we give confidence that this data will be secure. We will also mandate the use of common black box standards across all of the LHCRs so that we have a common way of, for example, de-identifying data and re-identifying data. So we are going to try and pull off the trick of supporting local innovation whilst not letting the dead hand of the centre rest too heavily on the shoulders of those doing the work. But we do need to manage that standards piece within that against our local innovation. That really probably sums up the challenge that every CIO and innovator has today. I don't have any slides on the DIH, but I just wanted to finish off with the Digital Innovation Hub. So I'm working very closely with Andrew Morris with OLS, John Bell and Mark Walpole. The Digital Innovation Hubs were trailed within the government's industrial strategy in the summer, and a couple of months after we have gone through this process to get local health and care records, there will be a parallel process that will commence to select Digital Innovation Hub. So we will announce our local health and care records exemplars in early to mid-May. We expect that DIHs will be announced a couple of months after that. There will be 3 of them. Andrew Morris from UK Health Data Research and I will be leading both of those pieces of work. We'll be making sure that we share as much common standards as possible, that where we have the same IG problem in both spaces, we'll use the same solution to address it. So we will have our first LHCR live. Please nobody tweet this because I'll only live to regret it, I'm sure, but our hope is round about in April, May 2019, and that we will at the same time have the first research uses of DIHs in similar timescales. So for me, just to finish, my background is actually in information management and operational research, not in technology. For me, a frustration has always been that the NHS has never really used data in the way that it can do, and has never really managed its data assets as it should. I think these LHCRs, the DIH work, is a real opportunity for us to completely transform the service and to transform our ways of working and to begin to build evidence-based practice in real time. So thank you for listening, and I hope you got all of that. I'm very happy to have time to take questions.
Thanks very much indeed, Will. That was very, very helpful. And to hear it from the horse's mouth is really good, because some of the communications about this as they've drifted out during the year, we as an HSN have sort of heard different versions of the truth from Chinese whispers, so it's very helpful. I've got a question, but we do have a roving mic for anybody that's got a question whilst you're here, and thanks for taking questions. One of them is about the digital innovation hubs. I'm hearing different versions of the expectation that the digital innovation hubs will be selected from amongst the local healthcare record exemplars. Is that a given, or may it be that somewhere may be a digital innovation hub, but not necessarily a care records exemplar?
I think it's fair to say that one of the areas that we've had most debate on. My perspective is that the areas that have most mature data sharing, the NHS and not necessarily those areas have got the best medical science research early on. So the position as it is today in this area that we are qualified is that we would like as far as possible for them to be confirmed, but we expect that they may not be co-service. So hopefully by saying that I've avoided the question altogether.
Thanks, Will. We've got a little bit of a signal break up there, but just to check, so the expectation is that it will be optimal if the digital innovation hubs are co-service with local health and care record exemplars, but it's not necessarily a given. Did we hear that right?
That's right, yes.
Thanks, Will. So we have one question from the audience. If you could just say who you are and where you're from.
Hello, yes, David Calder from Knowledge Transfer Network. About the hubs, again, is there any connection between these proposed hubs and the existing FAR Institute network in terms of data hosting and the work they've already done and the investment from MRC and that?
I think that remains to be seen. Andrew Morris is we've got very engaged with and what we're doing. So we will certainly build on the learning, but the extent to which we reuse that architecture structure depends on who selected the DIA. But I think we'll see that merge over the next few months.
Okay, thank you, Will. Any other questions? Yes, we have one.
Hi, Will, thanks very much for that. I'm Mark Guest from Health Watch Sandwell, and in the spirit of Health Watch, we're here to be slavishly patient-centred or customer-centred and hear a critique. Very interested in the longitudinal, wide-ranging care records. I think we'd say we don't think it's crossed the bridge into being fully patient-centred or customer-centred, I should say. I think it's still thinking from the service point of view, and goodness a trick. And how I'd see that being addressed is some kind of feedback from customers and patients on their experience of using services and why they're using them. So, in simple terms, it could be any complaints they have. It could be as simple as trying to get a GP appointment, couldn't get one. It could be at the end of a 111 phone call, giving some feedback on the experience, maybe saying, I'd like not to be asked my name and address 3 times, which I know is being addressed. I think the benefit of that is it really would become very patient-centred. It could give a fuller picture of the patient's health if they're reporting things that they never actually interacted with the service on. And I think it would also could give some very valuable live information on the state of services and where there could be improvements and where there are gaps.
I couldn't agree more.
Good answer. like that answer. And I think it's fair to say, just as from an HSM perspective, that's a central part of the conversation we have around digital. Is that if you lose sight of the opportunities and the value add that the citizen and patient-facing capabilities add, you're missing out on a huge asset rather than seeing it as a challenge. Thanks. I don't think we have any other questions. Well, thank you very much, and I hope you're not snoring for too long. And we really appreciate your time for the presentation and for the questions and answers. So, thank you very much.
Thank you for getting done.
Thanks, Phil. Goodbye. Well, very interesting. For those of you that have sort of been keeping a weather eye on local health and care record exemplars and digital innovation hubs, it was probably a nice crisp presentation of why they're doing it and what's happening. And I think it's fair to say when we get communications from central bodies, we often get a lot of why and an awful lot of the how. That's an awful lot of what, and lots and lots of the how we're told to do it. Not always a lot of the why. And I think it was refreshing to hear from Will that even in the five-pillar architecture, that the voice of patients and the patient focus is there. I'm now going to introduce Lucy Chapman from the West Midlands Academic Health Science Network. And for some of you, this may be revision, and for some of you, it may be news. But it's important to say that Digital Health West Midlands is part of the Academic Health Science Network. And the reason we exist is to spread the adoption of innovation. And over the last few years of our original licence, and Tony mentioned we're about to go into a new 5-year licence from NHS England and the Office of Life Sciences, we've developed a mechanism that really helps with the spread of innovation. Whether you're part of the care system struggling to find new ways of answering old problems, or you're an innovator knocking on the door of the health and care system. So I'll now hand over to Lucy to talk about Marie.
Morning everyone, there's nothing like a shift around in the agenda to get you ready for the day, so I'm up next, this is me. And so I think essentially what I'd just like to do, and for a lot of you who have already been involved in Meridian Health Innovation Exchange and putting submissions on there, it's really just a revision, but also just to kind of re-emphasise what it is that we're trying to achieve through our Innovation and Adoption Survey. So, whilst we support innovation from start to finish, of whether it's an idea, predominantly for our licence, we are focused on the adoption of innovation that already has proven its benefits, it's got demonstrated outcomes, and whether they are economic benefits or health benefits, and that's certainly where our focus is. So even though innovation doesn't necessarily mean invention, it's the fact that what we're keen to do is spread things that are already demonstrated that they're working. And I think sometimes the word innovation can put a bit of a barrier up because people think, well, I don't know if it's innovative or not, or is this good enough for us to adopt within the health service or the social care service? And actually, if it's not already done there and it can add value, then we're really interested to hear about what it is that you're doing. And I think one of the things that I heard very early on in my journey of the AHSN, and it was from Bethan who sat over there, is about the fact that you can't just push innovation without there already being a need identified. And I think that's sometimes something where people struggle with, is that they've got this fantastic idea, it's a problem that they face, therefore they're going to develop it further, but actually is that a wide-scale need? And is that something that everybody wants to sort of focus on? So one of the things that we've been doing over the last 4 years is really try to get the health and the social care service to describe its needs, not its wants, but what is it that you actually need? Because through identifying those needs, what we've found is that there is a greater willingness to work together to identify solutions and to pull those solutions into service, and then ultimately, bless you Chris, to commission them. Well, I'll do. So, for us, Successful health innovation starts with the problem and not the idea. And it's about how can we make sure that as an innovation agency, as Neil called us earlier, we are working with the system to make sure that those problems bubble up to the surface. And it's something that we're not really comfortable doing is then actually I've got this problem because it's quite embarrassing. You know, embarrassing bodies just put it out there publicly. Well, that's essentially what we're trying to do. It's for you to get your problems onto national television for everybody to look at. But it's how can we ensure that we then clearly define that problem and then work with the health economy, with industry and academia to identify the solutions that fill that gap. So a push without a pull is unlikely to succeed, and that's been our experience over the last 4 years and forever essentially. But I think it comes back to Mark's point around how do we make sure that we involve the service user, the end user, whether that's staff, whether it's a patient, to sort of co-design and co-produce what it is that we're looking for, so that those user needs really are at the heart of everything that we do. And again, it's about that return on investment. So how can we make sure that early on we are saying we need to identify how we're going to measure this, and then how do you attribute whether it's that solution or actually there was a policy change somewhere else, and that's how we ended up with these benefits. And is it health benefits? Is it economic benefits, or actually it's both? And that's what we want to focus on. And again, the whole reason that we focus on the need first is so that it becomes sustainable. You know, there are a lot of people early on used to go, so is the NHS a funding organisation? No, we're not. And the reason for that is that we want this to be a sustainable health economy where we can identify needs, put solutions in place that are then commissioned and brought as part of the way that we do things. So we sort of are aware of the NHS's needs and the fact that, yes, there are some trusts that still have faxes out there, even though I think in most businesses they disappeared a long time ago. It does have some systems that obviously need to be addressed. But then we've got a lot of people in this room that have technology that can absolutely address some of those needs. However, what we find is that they tend to bounce because of there's not enough time, there's data in silos, there's confidentiality issues. So whilst we're trying to address some of these issues, it's about saying, okay, how can we work in collaboration? Because otherwise these things will just essentially bounce off. Thanks to Neil for the animation. So we've developed Meridian. Some of you are aware of it, you've seen it and have used it, which is fantastic. But it's how do we consistently use this as a tool that people become more aware of and utilise in order to put their needs up there. So the campaign element is around the pull of innovation, and that's where we would like to harness all of that support from the region. So the way that we've decided to do this, and we've been working over the past few years to get this in place, is that we know that the Sustainability Transformation Partnerships bring together NHS organisations and local authorities. What we're now doing is bringing in the other partners, so industry, third sector, patient care organisations, universities, in order to be part of the AHSN Membership Innovation Councils. And this is where we can try to identify those system-wide needs that we can then go out and search for solutions for. And it's about finding those common challenges. So, you know, we're not going to be able to boil the ocean and look at everything, but it's about identifying those common challenges across the system that need to find innovative solutions. We have 3 membership innovation councils across the West Midlands. North covers Stoke, Staffordshire and the Shropshire, Telford and Wrekin STP patches. Then we've got 2 STPs in the middle, which is Black Country and then Birmingham and Solihull. And then in the south we've got Hereford, Worcestershire, Warwickshire and Coventry. And I think one of the key things is that we're keen to make sure that there's linkages between each of those MICs, so that if we can utilise the learning from one membership innovation council and then transfer that to another region, then hopefully we're reducing the time that it takes for some of these innovative solutions to get to market and get landed essentially. So the way that it works is that the Membership Innovation Council defines a challenge. These are then published as campaigns onto Meridian. Then there's some work that the Innovation and Adoption Service does working with, we've got MinTech, MedLink, that work as part of that. We've also got the networks that can help feed into this. We then try to match some of those solutions to the challenge to make sure that those that are most viable can be put forward and decisions can be taken as to, essentially, how can they be implemented and adopted. We've established task and finish groups so that we've got people that are closer to the operational working within the systems to then essentially support them to spread and get adopted. Now this is the theory, and it's starting to happen, and we had an example of the Break-In Free group where we presented their solution along with a number of others to support the need that was identified around alcohol-related harm. And now what's happening is that they had a solution that was focused really on the dependency side of alcoholism and looked at how we can move that earlier on around the prevention agenda to support people who think they may have an issue with drinking, because a lot of the work that was done with the dependent market is essentially the same as the preventative. And now we're starting to roll that out, and again we can see the benefits and then share that with the other membership innovation councils. Oops, gone too far. So we've got over 900 registered users, with 85% of those active and participating in the campaigns that are on there. Again, it's a digital solution where we're trying to crowdsource more information than it would be. I'm sure many of you have tried to get in the diaries of people within health and social care. If you don't give it 6 weeks notice, then you're struggling. But at least this gives us a bit more easy access to people to sort of crowdsource people's thoughts. We've had 292 published submissions. And again, 47 of those have been signposted to get support from within the West Midlands. So that's whether they needed extra evaluation, extra evidence, or they needed a partner to trial something, and that's how we do this. And again, the stories are there. So we have an innovation warehouse where we've got case studies. We were talking earlier around a piece of work that Echo is doing. How can we make sure that there's a case study? They've got work going on in different parts of the region, whereas actually they're a company based in the West Midlands. How can we maximise the opportunity that they can get to scale across the region? And then in July, we've got our Meridian Live event, which is essentially bringing everything to life. So what we're looking to do is to bring the STPs to that event, to bring their challenges where they can start to really design and work together to say what could some of these solutions look like. And again, the key thing is about celebrating innovation. We've got a lot of good stuff going on in the West Midlands, and it's about how can we shout about it. We always hear about what's going on in London, the northern powerhouse, but actually the Midlands engine is the one that we want to really get behind and champion and start really shouting about the benefits of working in the region. And that's it for me. Thank you very much.
Thanks, Lucy. So I'm now going to talk about the main reason why we asked you all here today, which is to launch Digital Health West Midlands. And after this, we'll do a bit of a Q&A slot, and Lucy will be available to take any questions about the specifics of Meridian. So we've heard the national context, that central government policies about driving greater use of digital innovation, better use of data to improve health and well-being. And we've got an academic health science network. There's this partnership between citizens and patients and the public, academia and industry, from global corporations through to start-up small medium enterprises and the health and care system to drive the spread of innovation at scale and at pace. And we measure success in better health and in wealth. So our golden spell is where a business in the West Midlands delivers an innovation that transforms the lives of patients, stops people becoming patients by enabling them to live healthier lives physically and mentally, allows our care professionals to deliver the sort of amazing care that they want to deliver, and in doing so attracts investment, jobs, export revenue to West Midlands businesses, in which case we've all won. So what is digital health West Midlands? Well, the first question is, what's digital health? And any use of technology, and that's data, that's information, that's knowledge, that improves health and improves care, and we make the distinction. The NHS has traditionally focused an awful lot of its energy and its expenditure, understandably, on sick people, often in hospital setting, to get them better quicker. But we all know that we've never really been able to invest fully in stopping them getting sick in the first place. So we don't just focus on patients, we focus on citizens living healthy lives. Technology can allow us to turn data into meaningful information, which becomes knowledge that informs decisions. Because really good health is about the decision, whether it's the decision I make about whether to eat at McDonald's or have a salad, or the decision about where to refer me, or the decision about what medication I need. It's also about enabling us to transact and looking at the parts of our lives that have been transformed digitally, and yet with the health system not necessarily that transformed. And it might be analytics, it might be dashboards and portals, it might be devices, it might be applications. And it can involve apps, but it's not just apps. And one of the frustrations we get is when we go to the NHS and say, I need an app. And it feels a little bit like me going into Halford saying, I'm not sure what's wrong with my car, but have you got a 17mm spanner? Just in case the problem's a loose nut, and just in case it's 17mm. And so that innovation pull and push is really critical, because the solution you need depends on the problem you're trying to solve. This is a recent piece of research out of the States about how quickly technology was adopted. And on the left-hand side, the axis is how long it took in years for something from its introduction to being used by 25% of the American population. And the background data shows that this is pretty much the same around the Western world. So electricity was first installed in people's homes in 1867, and it took 46 years before a quarter of the population were using it. The telephone took 35 years. By the time television came along, it only took 26 years before a quarter of the population had a telly. And when you look at Instagram, Snapchat, within 5 years, a quarter of the population were using it. Some of the more later interventions and innovations, we think are looking at a 12-month adoption cycle. And yet you'll often hear it said it takes 10 years for the NHS, the land of the fax machine, and I had to explain to my 25-year-old son what a pager is. Because he's not worked in a hospital, which is the biggest pager market on the planet. So we're not working at the pace that the rest of the planet is. And if you look at digital disruption, there aren't many people in the room who are old and wrinkly like me, but you know, does anybody who remembers those remember that faint smell of urine as you go? My kids don't know what one of those bloody things for. And do you remember when you had to go to the bank if you wanted any money, or if you wanted to pay some money in? But when you go there, oops, sorry, because they were only up when you were at work. But now we use those. Do you remember waiting with your market pen to put the circle around? The ones that you wanted to watch. Oh, come on, boys! Disney time! No, you just pull it up when you want it. You watch what you want when you want to watch it. Our worlds are radically different. Driving around London for the first time with an A to Z in one hand and a steering wheel in the other, hoping you didn't have to change gear. And now we just, well, on my car, I even talk to it. Hopefully that's what it does. You look at the NHS, how that's changed. You had to physically travel to a location to be seen and wait until they could see you. But now, it's a car. There's so many ways the NHS just hasn't really moved on. And if you look at that pace of innovation, The pressure is really on for us not just to better meet the needs of our population, but to do it much more quickly. I want to think about what good looks like. If we use digital tools, if we use technology and information, the people who live in the West Midlands can live healthier lives. They're mentally healthier, happier. When they do get sick, they can take more control over their diabetes or their asthma. They can self-care more effectively. When they need care, it's fantastic. And the care professionals can deliver the sort of care that they wanted to when they became social workers or GPs or surgeons and nurses. And commissioners, the faceless bureaucrats. I was one for 20 years. In 20 years working at very senior levels in the NHS, I've always said I met 2 people who didn't care. Out of the tens of thousands, people are passionate, whether they were running a spreadsheet or a scalpel or a prescription pad. And technology and better use of information and data can allow them to do that so much better. And what we can also do is allow the digital innovators, technology developers, whether you're Google or Apple, or whether you're a big pharmaceutical company, or whether you're a Fred in a shed one-man band, or one of the technology startups that's in this building here, to really deliver life-changing and money-saving innovations into the care system. And if we get all of that right, the money that flows into the West Midlands and creates jobs, and people with jobs are healthier. We've got this really good virtuous circle going on, and that's why we're here as an academic health science network, and it's why we're launching Digital Health West Midlands today. So what do you get? We're blessed with a bunch of expert advisors and partners. We've got clinicians, we've got technology gurus, we've got cybersecurity experts, we've got people who try to explain things to me that I don't understand, but I'm not smart enough. But you name it, we've got finance advisors, people who are experts on how to pitch an innovation, how, as a care professional, to understand the difference between somebody selling you snake oil and somebody presenting with a life-changing opportunity for your patients. The building we're in, iCentrum, part of the Innovation Birmingham campus, is a digital incubator and accelerator. So on the floor with a mustard line around it, we host our digital incubator for small and medium enterprise startups. And they've got access to all of that advice. We get venture capital experts coming in. We get people from Midlands, West Midlands who can advise them on industry portals and industry access into health markets. We've got clinicians. We've got commissioners, we've got health economists who can really help those businesses get their innovations that can improve health to really land and stick and become sustainable solutions to help the NHS move forward into the digital age. And for slightly more established small and medium enterprises, because our startups in the incubator get rent-free accommodation, this wonderful building and facilities, and that support. And the iCentrum Digital Accelerators for more developed ones. So if people have been in here for 6 months, but they still want access to those networks, to the commercial advice, to the clinicians, they get subsidised rent and they can stay here. And slightly more mature digital businesses come here. And I'm delighted to say we've got businesses that have travelled up from London, from the South East, from other parts of the UK, who want to be in Birmingham because of what is offered. Not just by us as an HSN, but by our partners, many of you in the room. We have a social enterprise incubator for third sector organisations. Some of these fabulous community organisations born out of concerned parents or patients or citizens who want to put something back into the health and well-being of their community. And the Fuse Social Enterprise Incubator down at Digbeth in Birmingham, again, gives them access to that expertise and some office space to really grow their social enterprise. And we do have an SME Innovation Fund, and Lucy said, we're not a funding body, we're not, but we did manage, through lots and lots of difficulties in terms of how public sector finance works, to effectively set up a venture capital part for SMEs. And it's a convertible loan, so anything up to sort of £40,000, £50,000. I've died. I'm back. At the end of which they can either repay with a very reasonable interest rate, or they can convert it into equity, which we then jointly have a stake in their business. So those services are available to the NHS. It could well be, in fact it is the case, that NHS clinicians might be innovators and have an innovative solution and want to use Serendip as the place to grow their startup. And we have an NHS clinician running a business here as part of that. But also for clinicians in the NHS, through Meridian, saying, has anybody out there got an innovation that can help us with X, with alcohol-related harm, with frail older people having falls, with young people becoming mentally ill when it's preventable? Not only can they find existing innovations within Meridian, they can also work with our SME innovation partners to develop innovative solutions, co-design them. And underpinning that, we have 3 networks, and I was really pleased with some of what Will Smart said earlier today. So you're probably familiar with the global digital exemplars. Those are the digitally mature NHS organisations that have been given an investment from NHS England to go from being some of the best in the country to being some of the best in the world. And we're blessed with University Hospitals Birmingham as an acute global digital exemplar, Birmingham Solihull Mental Health Foundation Trust, and Worcestershire Health and Care Foundation Trust. And West Midlands Ambulance Service have just been announced as one of the 3 global digital exemplars. Now they're going to be doing what they're going to be doing, but part of their challenge is to spread the excellence around the region. And so we work with them as global digital exemplars, that as UHB comes up with a really, really amazing way of improving efficiency or patient sensitivity of outpatient services, we can use our network to disseminate around the region and accelerate the pace of adoption. But what we can also do is where those global digital exemplars are scratching their noggins saying this is one of the weaknesses of our trust, then we can use Meridian to help them to source innovations that address those problems. So it's focused primarily on the global digital exemplars, but we, to be effective, will need to work with other partners in industry, in academia, in patients and carers in the third sector, and other parts of the NHS in the region, to help to really spread those innovations and to find better ones. So that's the first of our 3 networks that we're launching today, is the Global Digital Exemplars Network. The next one, Will talks about this learning environment, about learning to be more digitally capable as a system. So the Digital Health and Data Learning Community, it's regional. It complements the NHS Digital Academy, which provides an academic resource for people who want to be Chief Information Officers or Chief Clinical Information Officers of the future. But this isn't just for the people who want to be the leaders, it's to people who want to champion. You could be a nurse who's found that using some technology allows you to really improve the experience of your patients. You could be a patient who's found a way of transforming your relationship with your care professional. Anybody who wants to see much better use of digital health and data, to have a peer network of like-minded individuals, mechanisms to help you to spread and share that learning, and to find out how to become an even better digital health champion. One of the examples that we've given is, it's really interesting when you get a clinician with ambitions around digital in a room with a tech startup, just to realise how differently their brains are often wired. And you do get situations where the clinician's saying, well, we've got to do this, then that, and the entrepreneur will go, why don't you just do that? And the doctor goes, why don't we just do that? That's what we want to catalyse. And it works the other way. Because you get a tech startup saying, I'm going to do that. And that's the bit where a nurse will say, you do know that would be before my original professional body if I use that technology. Because you've not factored in some of the professional regulation that I have to comply with. So by sharing information across health, business, health and social care, commissioners and providers, and patients and citizens, we can really use the Meridian network to push some of the challenges out to attract innovation and to really improve the capability and the capacity within the region for digital to make a really transformative difference. And then finally, Health 2.0 West Midlands. Anybody here heard of Health 2.0 as a global movement? No, you're all too young. About 15 years ago, there was cloud computing was a new thing. And lots of people in health were frustrated that said, yet again, we're going to be the back of the queue in health. Transport will run away with this technology, retail will run away with this technology, the leisure sector will run away with this technology. of the queue. So Health 2.0 was established to say, let's have a look at what technologies are coming down the wire. What are the emerging technologies and how might they really transform health? So it's a global movement. It's really taken off in California, in India, other parts of North America. Australia's got very active Health 2.0 communities, and parts of Europe have got very active Health 2.0 communities. It never really took off. Birmingham had a Health 2.0, but for the last couple of years, it's not been extremely active, but the ambition's still there. So we're launching today Health 2.0 West Midlands. It's formally hooked in as a member of the worldwide Health 2.0 movement. And it's about the art of the possible. So we know that the first people to knock on the door to join Health 2.0 will be the geeks. And if you're a geek, you're more than welcome. But it's also about people who aren't geeks. So at the moment, 15 years ago, everybody's going, so I've heard about the cloud, but what is it? I've heard about Web 2 and virtual conferencing, what is it? Now people are asking, what's blockchain? What about virtual reality? What about artificial intelligence? What about augmented reality? So we talk to entrepreneurs who are saying, well, you could hold up a smartphone in front of you, a tube of ointment, and a little person will pop up on the screen telling you how to use that ointment properly, instead of the half a millimetre font that's printed on the packaging that we all just put in the bin unread. Virtual reality as a pain management system. We've gone off again. To distract people from the pain they're in using virtual reality. 3D printing. Did anybody see on the news recently of a heart surgeon who was really probably not going to undergo to undertake a heart operation on a very small child because the complexity meant the operation would be so long and so risky that there was a good chance the child wouldn't survive. But some geek took a scan and printed out a few versions of that child's heart in plastic, and the surgeon did 4 practice operations, getting the operation time down from about 4 hours to about 1 hour and 3/4, and enough confidence to go ahead and understand that the child survived. So these are technologies, but we've now got established ways of using them. Health 2.0 is the place that you can come together with your expert perspective, whether that expertise is clinical, technical, as a patient with lived experience, or as a parent, or as an academic researcher, to look at how we can really drive that. And I'm pleased to say, digital health ambassadors. They're the hamsters in the wheel that keep it spinning. So we've appointed 2, and I'm going to embarrass you and ask you to just stand up and wave, but Ravi Kumar has joined us as a digital health ambassador. Hi, Ravi. And Ellen Hughes is our second digital ambassador. Do please collar them at lunch. Ellen's so new she hasn't got a business card yet, but if you grab Ravi's or mine, we'll hook you up. And we are about to go to advert in the next few weeks for 1, possibly 2 more digital health ambassadors. And their remit will really be around driving those networks. Cheers, you can sit down now. I was going to give you another 5 seconds until your faces were really red. But a lot of our time will be making sure that the digital health and data learning community, that the Global Digital Exemplars Network and Health 2.0 West Midlands really take off and really deliver what you need. And before you leave today, I do want to spend a little bit of time, and we've got some bits of paper for you to scribble on later, to ask, what would you want from that? What sort of an event of Health 2.0 or the digital health and data learning community would make you want to traipse out in the snow to come and find out more and to play a part? So I've described the 3 networks, and I've also described the services, and I've also described the expertise. I've also mentioned that that's backed up with a bunch of clinical experts and technical experts that work with us. And that's what Digital Health West Midlands looks like right now. In terms of what we want to do in the next 2 years, is to grow the capability. We want to deliver analytical and integration support, again, to our NHS partners, to our social care partners, our patients and carers, our academic partners, and to industry. And it may well be that the West Midlands would opt or apply to become a local health and care exemplar. Once we've got that in place, we want to establish a digital test lab and a living lab. And I've been fortunate to work with people in northern Finland who've done something very similar, where there's a test lab that allows people developing technology to do testing against core health systems. So I love the idea that in 2 years' time we would have a facility where if you're a technical developer, you can work to not only develop amazing kit and amazing systems and processes, but test how they work with mainstream NHS systems. And the concept of a living lab really excites me, and that's why we want to have a network of people living in their own homes, in schools, in their offices, in care homes, for example, where we can allow developers and clinicians to test new patient and citizen-facing technologies with them in their own natural environment, in their homes. And it may be that a digital innovation hub, as that Will was describing, might be a vehicle to help us to make that happen. However it develops, we want it to develop with you, and we want it to develop for you. So, if you want to know more, our website's there. If you can email us at digitalhealth@whsn.org, we'll get that email and we'll get back to you. So for now, that's all I wanted to say, and I believe we've got a coffee break. But just quickly, whilst we've got Lucy here, do we have any questions that you want to ask, particularly about digital health, West Midlands, the networks, the services, the ambassadors, or about Meridian? I said coffee, didn't I? Yes, we've got one chap here. Cheers, Joe.
Yeah, I was just wondering how the Meridian and the networks are going to sort of integrate with the groups that are doing the digital roadmap, NSTP, sort of planning digital health.
It's a really good question. The answer is if they don't come and join, we're really missing the trick. Fortunately, we've got a really good relationship with a lot of our digital leaders inside the NHS and social care system. So, for example, we've done a lot of work as an HSM with Staffordshire Stoke on Trent and with the Black Country about pulling together their local digital roadmaps. But with all of the STP areas, we're in discussion with the digital leaders, CIOs, CCIOs, and with people like Health Watches about how we can make sure that digital isn't just an innovation and an innovation push, but the STP and the local digital roadmaps really fully align. So actually, some of the work that we've been doing that we're more excited about is about influencing the sustainability and transformation partnership to think more digitally and to embrace the local digital roadmap a bit more, rather than just say, oh, some guys over there are doing something about IT. So to make sure that there's real engagement. And saying to the LDR, to the CIOs and CCIOs, look, we've got a big thing in our STP about keeping patients out of hospital and caring for them closer to home. Where's that helped by your local digital roadmap? Where in your local digital roadmap are the solutions that will help us to make that happen? And the better ones are saying, well actually, that's why we want to integrate some of these records, and that's why we need money for data boxes and wires, so that we can make that happen, so that we've got a platform on which these digital tools can sit, that would allow a patient to have a Skype consultation instead of having to traipse through the snow to the hospital. So the conversation's already happening. One of the tests that I'm going to apply is if in 6 months' time, and we've grown the membership of our learning community, of Health 2.0 and our GD community, is that the people who are the influencers of those plans, whether they're STPs, whether they're LVRs, whether they're the new integrated care organisations and integrated care systems, or whatever comes out of government policy in the next 2 years, are actively participating in those networks. Because if they're not relevant to the people making the decisions about NHS technology, is that answer your question? Oh, Chris?
Be glad to know, Neil, this isn't a question. Just if anybody wants to know about the practicalities of getting your innovation onto Meridian, I'm here, I'm Chris Dyke from Medley West Midlands, and we're the innovation and adoption service on behalf of West Midlands. So Lucy was saying innovation so the whole of the NHS, especially out in the West Midlands, knows about your excellent product or service. Please come and chat to me in the coffees so that I can take you through that process if you want to know more.
Thanks, Chris. And I'm obliged to stop Lucy beating you up. That goes for innovation pull as well as innovation push. So some of you may have innovations that you want the world to know about. Some of you may have challenges. And I've got to say, we've got a chap over there with a question. And I've got to say, the assumption that came from some of our commissions from NHS England and the Office of Life Sciences is the NHS would be the person with the problem and industry would be the people with the solutions. Then you'd be surprised how frequent it's the other way around. And actually, some of our businesses are saying, I think my business could flourish, but I'm not sure how to overcome X. And sometimes it's the NHS or academic or patient partners that can help overcome that. So it works in both directions. So don't just collar Chris if you want to push your innovation. Collar Chris if you've got a challenge that you want us to help find an innovation for.
Yeah, Richard from Defence Medical Services. I'm interested in how you track, if you like, the radar tracking of innovations which are out on the horizon. So you mentioned 3D printing, which is, well, which are in the States. I've seen 3D printing of the heart practice that you've mentioned the £1 million 3D printer that they used at Rotary to do that. How do we here at the West Midlands kind of track that innovation? So, if I search your website and in 3D printing, will it come up with some sort of tracking? So I say, yeah, that's a really capability to exist, and this is kind of how we start to plug into it within the West Midlands.
Okay. If somebody submitted an innovation onto a Meridian that involves 3D printing, if you're on Meridian and you search 3D printing, it will come up and it will say there's an innovative solution for heart surgeons around 3D printing. I'm not aware of any that are on there, by the way, that involve 3D printing. That's part of it. But actually, what you just described there is one of the reasons why we want these three networks to be as inclusive and engaged as possible. So the obvious point for something like that would be the Health 2.0. So one of the things that Ravi and I are talking about with Hugo and Chris have been involved in Health 2.0 for a while, is in a few months' time, what topics do we want to cover at our first Health 2.0 meeting? And 3D printing may be one. And actually, if lots of you join up to Health 2.0 and want to know how might 3D printing drive extra value into health and care, then that's the subject we'll find. And what we can then go and do is find somebody who really, really knows about 3D printing. We've actually got one in the building, and to my knowledge, none of our health innovators have used it yet. But Health 2.0 might be the catalyst for that. Similarly, blockchain. Blockchain's driving an awful lot of things like new currencies and really innovative ways of using data and getting value from it. So already one or two people are saying, could somebody come along and give us a definitive what actually is blockchain? Because I keep hearing lots of BS descriptions of it from people who may or may not understand it. And how might blockchain deliver value into what we're doing? Another one's artificial intelligence, where we actually have quite a lot going on. One of the innovators here, we introduced them to IBM, and so the Watson artificial intelligence engine is actually driving a Birmingham born and bred digital health and wellness platform that's now being invested in by employers who want to use it to reduce their staff sickness. And it's a practical example of artificial intelligence, which is always in the news, but what does it actually do? And we have a global technology partner in the West Midlands as part of our test bed, working with mental health, social care, community care and police partners to look at how we could use artificial intelligence to derive meaning that's already sitting locked away and hidden in health records, and use that to transform our ability to predict crisis and help people before they get really sick. So I'm conscious that the coffee's...
Neil, just a question if I may. So on World Smart slides with the graph with the map of the UK, was a big red splotch around digital maturity and all shared care records around the Midlands.
No.
Are there any thoughts of how what you described here might help in that digital maturity of check their records?
Yes. There isn't a simple answer. One of the conversations that we are brokering with some of our partners, particularly the global digital exemplars because of their already identified maturity, is about whether it's as part of the local health and care record exemplar or simply some other collaboration that we might help to foster, is to come together to drive up the value of what's already happening around integrating records. There are issues with the data quality of that map. So, for example, I know people who will tell you within 4 of our mental health trusts that have already now found ways of sharing access to records across different mental health trusts to help avoid people with mental health problems falling down gaps. In Birmingham, there's Your Care Connected, which is quite an increasingly sophisticated model. University Hospitals Birmingham has got My Health, which allows patients, and it's a growing proportion of patients at the QE hospital, to have access online to their full record, notes and all. So there's a lot going on. But the West Midlands hasn't always had a very good track record of joining it up and singing about it. So maybe a local healthcare record exemplar might be a vehicle to bring that together. The other issue that I had invited a speaker who sadly is snow-struck again was Mike Dennis from Oxford Academic Health Science Network, and Mike was going to be talking about a place-based maturity model, because all of the maturity models that have been done around health technology are focused on individual organisations, which any parent or patient will tell you, I don't expect one bit of the health system to be in charge of my care, I expect it all to join up. And so what Mike in Oxford has led, working with Manchester and academic partners, is established a self-assessment maturity model for health economies. And Mike was going to be presenting that today, and I wouldn't do it justice by running through his slides. But at some stage, probably through our digital health and data learning community, I'm going to get Mike up when it's sunnier to present that. And already I'm hearing a bit of appetite from CCGs, acute trust, community and mental health services, and perhaps social care as well, saying, wouldn't it be really good to link arms and look at how mature we are as a system? Because we all know from our experience in the health and care system, you can have an organisation that's very digital mature, but if there isn't the interoperability, the patient doesn't really feel like it's mature. There's other areas where individually they may not be that mature, but they've done an awful lot of work about making the care seamless, and it feels more mature to patients and to carers. So that's part of the agenda that we want to bring together. And now, coffee. So the agenda says we will be back at 11:50. Let's stick to that. So coffee is served just there, Lou's are over there, and see you back here in 15 minutes. I have mentioned we're going to shuffle the agenda around. Obviously, we lost some of our keynote speakers this morning. So we're going to start again now. And the presentation from this afternoon, which is about digital transformation in mental health, is going to be next. As per my earlier statement, it's probably not wise to hold a panel discussion with a panel that isn't here. So the session that was scheduled for 3:20 about the networks, we're going to do after this presentation, and that will take us through to 1 o'clock for lunch. We'll have an hour for lunch and networking. I know there's 1 or 2 people I want to speak to and pick up conversations I started earlier. And please do get to know Ellen, and get to know Lucy, me, and Ravi. Then after lunch, the next speaker is going to be Professor Simon Ball, talking about his perspective of being a global digital exemplar. And then we're going to have a very short wrap-up session, and I'm hoping to wrap up round about 2:30, because it's horrible out there, and the white stuff's starting to come down a little bit, and I know you all want to get home and warm. So, without further ado, I'm going to introduce a man who's been around since actually before the inception of the HSN. He was around as part of its formative phases, and Peter is a consultant psychiatrist, and he's our clinical lead for mental health. And I've asked him to talk about his experience of how digital health and data and technology can really transform mental health and well-being. So to you, Peter.
Great, thank you, Neil. I'm really feeling ancient now. I haven't been around forever, have I? Okay, so thanks, Neil. Right, so I'm going to talk a little bit about how digital technologies has already influenced mental health programs throughout the UK and also in the West Midlands. But more about the future that is in store for us in relation to the opportunities available for us to take advantage of the emerging technologies. And I just want to start with perhaps looking at some of the ground that I think Neil has already covered. But just to mention that when we're talking about digital technologies influencing clinical services, we're talking about a whole range of different ways that we could do this. We do incremental innovations already. For instance, the trust I used to work for many years ago, we introduced digital dictation. It was a fantastic thing at the time. That did away, remember, with those devices that we used to carry around with hundreds of little mini tapes that we would take our clinical experiences on and so on. So digital dictation kind of did away with that. And then that evolved into electronic healthcare systems that we introduced in the trust later on. Surprisingly, we still have a situation where many trusts do not have electronic patient information systems in place, which is quite remarkable when you think about this technology has been available for many years. But that's an example of incremental and sustaining type of technologies that we have made use of. Then there's disruptive and more radical technologies that we and innovations that we have introduced and we're increasingly be introducing over the years. And some of those are actually revolutionary type innovations. We have examples of that in terms of digital photography, and in the field of mental health I'm going to speak about a few of those shortly. But this involves taking risks, and innovative organizations must give clinicians the freedom to develop ideas, because some of these revolutionary, innovative, radical ideas will fail. In fact, maybe most of them will fail. But the one or two that succeeds are really those that have the opportunity and wherewithal to be able to transform how we deliver healthcare services. So the dilemma then is that how do we identify a technology or innovation that's going to be falling in that category of being able to revolutionize how we do things? And in fact, we don't know. We will never know. I mean, look at these statements concerning the PC. I think there's a word market for maybe 5 computers. This was from Watson, the president of IBM at the time, a long time ago, but nevertheless, there it is. Now we have thousands, millions of computers that we wear on our wrists, basically, and not to speak of the computers that we carry in our hands through use of our phones and so on. So, disruptive technologies are so superior to the current product in the market that it renders them obsolete. This is critical. We're not talking about using technologies to put a layer on top of something that we already do. We're talking about technologies and innovations that really replace what we do, and in that way fundamentally influences how efficient we are with delivering services, fundamentally influences the outcomes that we expect, fundamentally influences the practicality and the usability. So it's not about a statistic I saw recently where it said that something like 20% of the time of a nurse on an acute ward is concerning actually doing paperwork. You know, it's about how do we use technologies to be able to maximize the use of our time by our clinicians in a way that contributes towards benefit of our service users. So in terms of mental health, we have a few examples currently of technologies and innovations that are really, truly the potential of being quite radical. So this technology, avatar therapy, was basically invented by Julian Leff several years ago. And basically, in my field, in mental health, working with people with very severe mental illness, very frequently these people hear voices, and the voices are very real to them. And the voices can be really quite destructive to their own egos, as well as destructive to people. For instance, a type of voice would be a voice that's what we call a command hallucination. A command hallucination is where the person experiencing it has to do what the voice is telling them to do. And that can, as you can imagine, result in tragedies, and has resulted in tragedies. So we, in mental health, are stuck many times in relation to influencing those voices. Antipsychotic medication sometimes helps, sometimes it does not. So we are really in a situation where we are open to being receptive to new ways of dealing with this. And Julian Leff came up with this method of avatar therapy, which is where he created a digitalized version of the voice that the person hears. Okay, so that this digitalized version is pretty close to what the voice hearer recognized as the voice that was in his head, basically. And he then developed a technique to be able to be the voice. So the therapist becomes the voice as well as the therapist. So over time, the idea is that the therapist is then able to influence what the voice is saying to the person. Gradually, over time, the voice gives over power to the voice hearer. Okay, so the voice hearer then feels empowered to deal with this voice, which previously was controlling him or her. Okay, now that's potentially revolutionary, and this is being tested. The other area that's very interesting is the chip in a pill. So this is a drug that's taken orally by people with psychosis. It's called Abilify. It's an antipsychotic, and the company has now developed Abilify Mycide. And basically, it's inserting a chip in the pill, so when the pill is ingested, the therapist, the doctor, knows that the person is taking that medication. Now, you may think it's a fairly straightforward thing, but there are many people in this audience who are taking pills. Some of you may be taking statins, some of you may be taking stuff for your hypertension, some of you may be taking stuff for diabetes, a whole range of things. Do you take it every single day? Do you take it 3 times a day? Do you take it twice a day? And I'm sure that we have all missed out taking the pills on some occasions. And that's how then does the doctor know to understand whether the drug should be increased or not? Or how does he understand how we should relate that to his diabetes situation in terms of glucose levels and so on? Okay, so this is the beginnings of using technologies in order to inform the caregiver as to the accuracy of the performance of the drug in relation to the condition we're trying to treat. Now, my issue with this is that I really don't understand why they chose a drug for psychosis. Because can you imagine my patients who are really paranoid? It's like, hey guy, you know, you're going to be taking this pill and it has this chip in it and it's going to, I don't know why they chose it, but there it is. This is the first drug that they chose to do that with. And this is how it works. The patient takes the pill. Once ingested, there's a sensor in the pill, sends the signal to a patch, you have to wear a patch, and then the information is available on the app, and then that information is available to whoever the patient chooses to make it available to. So it could be, it could actually be a carer. It could be a carer, for instance. But obviously that's something we need to work on. But this has the potential for being seriously disruptive, you know, as the technology advances, and you could easily see the application to a whole range of different conditions. You could also see how we could, as clinicians, become more accurate in terms of how we treat certain conditions, and so because we really know what is really happening. Okay, so technologies like this, as with every innovation, has its cycle, and we have early adopters initially. So one of there's another innovation that's that's being tested by a few trusts in the UK now called Slow-Mo, and that's innovation of where it's an app and encourages the, again, person with psychosis to deal with paranoid thoughts, right? But the thing about Slow-Mo is, of course, it's now in the stage of early adopters, so a few trusts that are testing it. If that works well, then we go into the next phase of the adoption of an innovation, which is spread of a particular innovation, and that's admittedly that's actually quite difficult, because with the early adopters you get people already sold on this thing. They're nerds like myself who like these things, and we say, okay, yeah, we'll try it. But then the non-nerds are more resistant, and the system basically is more resistant. Commissioners are more resistant because they like to have immediate answers and set up. So it takes more time for the early and late majority to become, and then of course we have the ladders who are stuck in their ways of doing things. But they are a small group. The main group that we want to influence with innovation are the early majority and the late majority. In Birmingham, we developed an approach using technology for a program that we ran a few years ago in relation to enhancing the information that young people get, the information that will lead them to understand their particular condition or lack thereof, and focusing on helping them to access the programs that could help them. So this program delivered digital tools to support young people with mental health issues or concerns, and we developed a website called Youth Space, which was really quite a remarkable development. I mean, as it matured, we had about 300 pages of information on Youth Space, and it was readily accessed by young people. It was created in a co-production arrangement with a youth board who contributed a lot of the content, a lot of the ideas in terms of what it needed to look like. And it was frequently accessed by young people who wanted help and advice about what they were experiencing, who wanted information about local services that might be available, and who wanted direction to professionals. And now we have the opportunity, because we have now brought together a number of partners who are so encouraged by how Youth Space developed, that we want to expand it, so that, for instance, we could have a schools platform, we could have a platform for the community. In other words, it would be one location where people could come to for an understanding of the problems that affected young people and how they could get help, and also how they could use technology that would be embedded in the Youth Space website to deal with their conditions. So, for instance, along with the development of the website, we developed a number of apps, one of which dealt with attention disorder, for instance, and another which dealt with psychosis and dealt on the silver linings, and it really assisted young people, particularly young people in early intervention in psychosis programs, to manage their condition in a way that was more acceptable to them. So you could see again how this the concept or place on the net that young people would come to get advice and to share experiences and to be directed towards teachings that could help could be enormously helpful. And we're working with a multidisciplinary group now to expand Youth Space and to introduce technologies that will more easily allow that to happen. It's quite remarkable that the use of a smartphone by age group is hugely significant now. This was sort of studied done, what is it now, 3-4 years ago. The use of smartphones has increased significantly since then. I'm made to understand that something like 1 in 7 of us now wear a device on our wrist to track steps and to track things that we do, activity and so on. it's huge. It's no longer something you can say, well, if we can get people to do this, then they will have the equipment in place to be able to access the tools that we develop. They have those tools now, with one proviso, which is that we have to be very careful that technology doesn't become a divisive and contribute to inequalities in how we deliver healthcare. For instance, how many of my patients who suffer from severe mental illness have a smartphone? How many have a tracker device? Especially those that live in deprived environments like Hammersworth and many of the localities that we have in Birmingham. How many have a tracker device? We say 1 in 7 have a tracker device, but how is that divided up in relation to people in poverty and so on? So we have to be careful with that and be cognizant of that as we go along. So it's not just about technology. It's not just about introducing the apps and introducing the programs and introducing the equipment that's required. It's also about thinking through how we ensure that we bring the population that we're responsible for along with us. Okay, I just want to say something now about Rail Plus, because Rail Plus is a test bed that we started working on in Birmingham about 2 years ago now. It's quite mature now. In fact, it's approaching time when the first phase of the Rail Plus project is going to be completed. So it's trying to reduce both the incident and intensity of crisis care, and how the test bed works is that it brings together providers and entrepreneurs, basically, and business in order to look at the problem and to work towards creating a solution. So we worked through the test bed with an organization called Telefonica. Telefonica Alpha, to be exactly, which is based in Barcelona. And that's the division of Telefonica that really is trying to, they call it the moonshot division. And that's what they take chances and they do things that they think may pan out to be something that's going to be actually profitable, but they will be helpful to the population also. And they're working with us on Rail Plus, and Rail Plus basically is doing this, and the bits in black is the thing that is contributing to, and the things in orange are the things that we already have in place. So Rail Plus is about bringing together all the things that we do in crisis care in a coordinated kind of way and introducing these new elements. So the bit of it that I really want to focus on is predictive analytics. Because that's the area that is potentially huge in relation to disrupting healthcare. So predictive analytics, and it progresses like this, where we've got vast amount of information in relation to a particular condition that we're trying to address. We already have that information. I mentioned earlier, so through introduction of electronic patient information systems. For instance, in our trust we have REAL, which is our electronic healthcare system, and vast amount of information. However, as you might expect in mental health, a lot of it is narrative. It's not a lot of the kind of information you get from the acute hospitals, where you have blood tests and you have investigations. It's not how it works in mental health. There's a lot of stuff that's to do with narrative. And the reason why we're able to look at predictive analytics work in relation to mental health is because computing power is now so enormous that through machine learning we can look at narrative information. Okay, so we have that information, and we want to progress through predictive analytics to diagnostic analytics, which is where we seek to understand what is it that this information is telling us about this particular condition. And then we go on to answer the question, why did it happen and what will happen? Okay, so why did it happen? With the machine crunching this vast amount of information, what connections, what algorithms can we look at that would predict, and in this particular situation, we're talking about crisis. So the idea is that eventually we arrive at predictive analytics and algorithms that are going to tell us who is likely to get into crisis. Now, in mental health, we already have risk assessment tools that we use. They're not very good. It's just not very good. we spend hours of training on these risk assessment instruments. We go to court and speak to the judge about the likelihood of this person murdering somebody again or stabbing someone again, and we use these risk assessment instruments, and they're just not very good. So we would really like to be able to be more accurate, a lot more accurate in terms of predicting who's going to become unwell and who's going to go to crisis. So this is what we're hoping will come out of the work we're doing through RAID Plus. The whole rationale is that we are seeking to predict and prevent crisis by segmenting in this case, real data by risk and attempting to predict those that are likely to go in crisis in the next month or so. So what that will then mean is that the mental health team will be to focus more on those individuals. We expect that through that we'll gain great insight into predictive factors, increase ability to predict a mental health crisis, and early intervention, so reduction of crisis can occur. The thing about that makes it extremely important, of course, is that what we hope to do is to reduce costs, basically. Costs to the person who's actually a patient, of course, because it's extremely harmful for someone to go into a mental health crisis. But also reduce costs to the healthcare system, because we want to intervene earlier, so the more costly elements of care don't happen. And that's the way that we hope to make a case to our commissioners that this should be become widespread as a technique across the healthcare system. So, in terms of predictive analytics, if you just extend the vision of it out of crisis now to other situations where disease comes about, diabetes, for instance, or hypertension. Yes, we know what diabetes is. We know it's to do with insulin resistance. We understand the workings of the pancreas. We understand these things. We understand hypertension, we know how to read it and so on. But we don't fully understand what contributes to the development of these conditions in people who belong to the same pool in terms of demographics, and some of whom get it, and some of whom don't. We are beginning to see the emergence of information in relation to genomics that's beginning to tell us a lot more about that. You remember when we did the first mapping of the genome, and everybody was so excited. This was over 15, maybe 20 years ago, and said, why? Once we have done this, then it's sorted. We'll be able to now identify the gene that's responsible for diabetes, and that doesn't work that way. Now we understand that there may be over 400 genes that are responsible for these different conditions. And how do we map that? Well, we're beginning to do that. Each of those genes, each of the 400, may just contribute 0.01% to the emergence of diabetes. But if we pool them all together and do the machine work and learn work that contributes to that, we may be able to get a clear understanding of who are the people who are at risk. And we could do that in mental health, in terms of predictive analytics. We know, for instance, that young people who have experienced more than 3 or 4 adverse childhood experiences are something like 40% more likely to develop a mental health condition later in their lives. 40% more likely. And it's not only mental health, it's to do with conditions that relate to the criminal justice system, it's to do with poverty and success in their lives. And if you have 3 or more adverse childhood experiences, the chance of your developing that is huge. Okay, we know what those adverse childhood experiences are, but what we don't fully understand is whether there are other things that we could look at that could allow us to understand who are the young people who are at risk. And again, with predictive analytics, as it becomes more sophisticated and more advanced, we may be able to do that. So, we've already started the work. We're already on the pathway. There are things that we are doing, that will, some of which will work out to be things that are useful in terms of disrupting healthcare, but the enormous bit of it, the bit of it that's under the water level in terms of the iceberg, is huge. There's huge potential for us now engaging with our technology exemplars, engaging with the young people, some of them occupying this building, for instance, who have great ideas in terms of connecting with our healthcare systems, and we need to take advantage of that. The recent development in sensor technology, online psychological therapy, some of which I mentioned already, remote video consultation, mobile applications, gaming, all present us with great opportunities to engage and empower patients to participate in what I feel could be a transformation of our healthcare delivery systems. Thank you.
Thank you very much indeed, Peter. Are you okay to take one or two questions if people have them? You can see why I enjoy working in this field so much when you get to work with Peter Lewis. Joe.
Hi, yeah, I'm Joe McCardle from University Centre Shrewsbury. In the danger of sounding like a Luddite, and really do believe in the drive of digital technologies, but I would be really interested from your view, particularly from a psychological component of it. Are we doing enough consideration as we look at our implementation and transformation services of the psychological harms and connections associated with a wide mass population use of digital technologies? We already know that blue screen issues around sleep disturbances and other things. So again, we keep pushing forward, but I suppose if we look at the medical model with prescription drugs, we start to think about the side effects already as part of the clinical trials. I'm not quite sure whether we really are mature enough to think about the long-term impact on our population around this as well, and develop that alongside the work programs. And I'd be really interested in your view from a psychological and psychiatric perspective. Are we looking at within some of your programs?
That's right. I mean, if you look at the use of Facebook and social media by young people, you see just that thing, don't you? You see the enormous potential of using social media and enormous things that social media has done for us in relation to understanding our communities and our world and connecting with family and all these things a lot better. But we see the downside of it in relation to what young people experience in relation to bullying, for instance, in relation to fake information that comes to them about weight and weight gain. I mean, one of my colleagues working with eating disorders is looking at that very thing. There are sites that actually promotes and encourage young people in order to use techniques that leads them to lose weight, to arriving at situations and conditions that are seriously detrimental to their health and so on. So there's a downside, and there's work happening in relation to looking at that. There's a recent publication by Dr. Goodyear, University of Birmingham, that has looked at a whole range of issues in relation to use of mobile technology and the detrimental bits of it in relation to how young people experience it and so on. So yes, you're right, we need to look at that. In all areas, I mentioned avatar therapy. I mean, what is the downside of that? And as I said, in relation to somebody who's already paranoid, dealing with things that you would see easily being transformed into an understanding that feeds into the paranoia. So yeah, it just opens up a whole new area. So yeah, we look at both the benefits as well as the consequences.
Just to add to that, Peter, I've just had a message from somebody who was driving from Essex City to come here and they finally had to turn back somewhere, Gloucestershire way, who works for NHS Digital and is leading some incredibly impressive work around the concept of digital safety in digital health, both in terms of how digital innovation can support safety, but how it can introduce risk and harm, but also the safety of the technologies themselves, and working with us, working with Warwick Institute of Digital Health, a chap there called George Dispotti, who's done a lot of work about the safety implications of digital health and health technology. And I can look at George afterwards, he's a nice chap. And Stuart Harris from NHS Digital. One of the things we want to do, probably in partnership with our digital health learning community here in the West Midlands, is to really understand that. Because one of the things that I'm excited about being part of the HSN is, it's the only place I know where we can have a discussion around the table from subject matter experts, including a psychiatrist, an academic, somebody representing patients, technology gurus, cyber security experts, all around that issue of improving the safety and mitigating the risk of introducing new law. So it's a huge question that we're really interested in ourselves. Any other questions while we've got Peter? Thank you very much indeed, Peter. Right, we've had lots of people working hard up here to your time. But the good news is we've got just over half an hour to lunch. So what I'd like to do is, on your agenda, there's a slot that was down as networks at 3:20. So earlier you've heard me describe the digital health and data learning community, you've heard me describe the Global Digital Exemplars Network, and you've heard me describe Health 2.0 West Midlands. And dotted around the tables, there are these pieces of paper. This one's an example. So this one is about West Midlands Health 2.0. And each table's got a different one. We've got half an hour, so you may be able to float between tables. But if you're particularly interested in the Global Digital Exemplars Network, find the table that's got the GDE paper on it. If you're interested in Health 2.0, find the table with Health 2.0 on it. And if you're interested in the digital health and data learning community, find one of the tables with that one. All I want you to do is have a heated debate, as Mrs. Burton would say, have a discussion. And what we really want to know is, what would you want from that network that would make you want to join, make you want to participate, and make you want to come along to events, meetings, and online collaborations. So it may be that the subject matters that are of particular interest to you. It may be the way it works. One of the things that we're committed to is all of those networks need to involve that combination of the clinical perspective, the managerial perspective, the patient and carer and citizen perspective, academics and researchers, commercial organisations, big and small, all around the table sharing their expertise and perspectives. So think about what sort of things you would like to explore that might get you travelling out to Birmingham, or hooking into a video conference, or joining an online discussion group, or a virtual network, how you might want it to work, what you might want to explore. So if I can ask you to spend 20-25 minutes, we don't necessarily need comprehensive notes. Some of us are going to be floating around, so I've already introduced you to Ravi and Ellen. We've also got Sarah and Chris from Medilink, who has spoken earlier. And we'll be just floating around, so if you've got any questions, just give us a wave and we'll come and help you. All we want to do is capture the headlines of what you would want from those networks. And that way, this is the co-design bit. This is about you telling us how those networks can deliver value to you. And that's what we'll do. Okay? Any questions? Okay, so we'll do that, and I'll give you a shout when there's a few minutes to go. Just capture the headlines on that piece of paper. So if you can nominate somebody whose handwriting is legible, that's my cop-out for never been described. We're not going to do death by feedback, we're going to capture it all, we're going to share it back to you, so all of you that have registered, when you get the notes and the evaluation request, you'll also get a summary of what people said. Thanks very much. Find a table, mingle, chat, and tell us what you want. Thank you. Who managed to battle through the elements to get there, and then you were that final cohort, the one who didn't sneak off after you nicked your buddies. So thanks all for being the diehards. The last oral presentation of the day is from Professor Simon Ball, who's the Director of Digital Healthcare at the University Hospitals Birmingham. We've asked Simon just to give you his perspective on the experience of leading a global digital exemplar acute trust. Over to you, Simon. Thank you.
Thanks very much, Neil, and well done everyone for being here and staying. So I received this style of GDs at West Midlands perspective, and perhaps I'll talk a little bit more broadly about the place of digital healthcare in the West Midlands as I see it, and of the West Midlands in digital healthcare. The GDs that have been awarded in the Midlands include UHB, those two mental health trusts, and of course West Midlands Ambulance Service. And you will have heard something around the mental health trust perspective, I guess, from Peter. I'm sorry that I missed him this morning. The last time I saw Peter, he had a very large glass of Rioja in front of him. So I was keen to hear him making a sensible of this. I started off by actually asking myself, well, what is an AHSN about? What is it really about? And went to the NHS England website and came up with this, which definition, which, if nothing else, is ambitious in as much as it includes education, research, informatics, innovation, training and education again, and healthcare delivery. If one undertakes a bit of text mining on this, if you will, or perhaps text culling, I think that a significant component of the AHSN's role is around developing, evaluating and promoting best practice. And I'm really going to try and think about those particular features as we move through the next 20 minutes or so. I'm going to give you a few examples and particular perspective of the way that best practice can be delivered using electronic systems. Because I think global digital exemplars, by their very nature, can provide insights into how we use electronic systems to do just that. Much of the dialogue at the moment is around blueprinting, and there is a propensity to end up reducing blueprinting back to dealing with the technical and the business challenge, whereas I think that we need to keep in mind what the transformational challenge is in terms of clinical benefit. And that is not simply about implementing an electronic system, as I think I'll nicely demonstrate here. Sorry, I'm going in the completely wrong direction here. Maybe I'll stick to this thing. So, venous thromboembolism is a bad thing. A DVT can cause your leg, in this case left leg, to swell and be painful, and more to the point, the clots that are in those deep veins can fire off and cause pulmonary emboli. So those clots, those dark bits that those arrows are pointing to in this CT pulmonary angiogram are bad for you. Pulmonary embolism is a leading cause of sudden death following major surgery, following orthopedic surgery, following inpatient stay of any sort, particularly if you have an underlying cancer or inflammatory illness. And so in 2009, the Department of Health mandated the assessment of the risk of venous thromboembolism, really pioneered by Bruce Keogh, latterly and now more recently of this parish. And in order to do this, we implemented that risk assessment in the setting of our electronic systems. And so we achieved 100% concordance with the assessment the moment we went live with this, because we built it into our admission process. That's all very well. However, this seemingly simple task is actually rather complex. So built into the national model of venous thromboembolism assessment was an option to postpone assessment pending further information, and not only that, there was no hard interconnect between the recommendation and actually undertaking the recommendation. And consequently, if you look at these data, I'm not going to go into it in data, but historically, our compliance rate with the prescription of prophylaxis was around 45%. That's despite the fact 100% of our patients were being assessed. So that's a bit of a problem. So we went around a variety of approaches to redesigning our electronic health record to actually achieve the result that we thought we'd hoped to achieve, or we had hoped to achieve, very much more simply. So, for example, we then added in alerts to point out that Bilbo Baggins here, despite having been recommended that he receive enoxaparin, had gone 24 hours and it still hadn't been prescribed, and we started to see increases in the rate of appropriate prescription. But we were still significantly below where we thought we needed to be, based on some simple, straightforward audits undertaken by our haematologist. So we were at around a prescribing rate of 70-75%. And to cut a long story short, we went through a whole series of changes to the electronic healthcare record, including automated proposal prophylaxis, and then ultimately prescription prophylaxis, that then demanded that the junior doctor, who was generally the person admitting the patient, actually stop the venous thromboembolism prophylaxis if they thought it was inappropriate. I think it's a very interesting kind of piece around the psychology of the way that people make their choices, and concerns the disproportionate concern over errors of commission rather than errors of omission. And I think it also speaks to the way that that shift working has changed attitudes and what have you. But that's really beyond the scope of today's talk. To cut to the chase, following making all of these changes, we now see a rate of compliance of around 91, 92%. And you can see that most of our junior doctors are really performing extremely well, with almost no or no omissions in response to the recommendations. But I'll just take you through this particular piece of data very quickly. This is the proportion of patients in red who are not compliant with venous thromboembolism prophylaxis. You can see we've made a big change in the way that the question was presented to the junior doctors here, and we get down to around a 5% rate of concordance with the recommendation. And arguably, one can see that there may be, on a month-by-month basis, there a change in the readmission rate with venous thromboembolism, which is represented by these blue diamonds on a month-by-month basis. So this is VTE readmissions per 1,000 spells, both before and after that change. Of course, it does point to the difficulty of actually doing these analyses. What it does suggest is that we weren't doing harm, we weren't making matters worse, but it is significantly difficult to do these analyses when you're not doing essentially a classic randomized controlled trial, because clearly there were lots of other changes happening in the organisation. The other question that we asked ourselves was there something about the design of the question of the healthcare record that determined the fact that we didn't get the initial response that we expected? And one way we went about this was to look at the accuracy of VTE assessment and response to that VTE assessment at a junior doctor level, and then to look at a variety of other kind of motherhood and apple pie questions that were formulated by some of my colleagues to look at junior doctor performance. And interestingly, poor performance on one parameter was, perhaps not surprisingly, but was associated with poor performance on other parameters. So our approach to that was then to take those data and essentially to normalise them and integrate them and provide a Z-score for each doctor. So that's essentially how far are you away from the mean of your classmates, as it were, in terms of performance. And you can see that we actually have quite a significant spread, and we have some significant outliers in terms of performance. And some of you will have heard this described before. These particular doctors were asked to attend a clinic held by some of the clinical educators, and their performance discussed. And it is not simply that these are bad doctors or bad people. The motivation and the reasons that they underperformed were complex. Nevertheless, having come in, their performance significantly improved. I won't show you the data for that. I think much more interestingly, the performance of the whole cohort improved. So there was a significant Hawthorne effect. The junior doctors' mess, as it were, rapidly heard what was happening, and their behaviour rapidly changed. So I think, and the other interesting thing to say is they didn't know exactly what parameters we were examining either, and it happened across the board. So I think this talks to the fact that actually undertaking electronic healthcare record implementations, the benefits that can be realised are not straightforward. They require intelligence and an intelligent approach to not only design, but also the way that it's used to affect behaviour in the organisation. Because if you try and rigidly apply a pathway approach, then you end up with as many difficulties. So we don't design systems that are entirely rigid. We design a certain degree of flexibility, but you need people then to use them, and you need to influence the way they behave. So our approach has very much been, as many of you will have come across, has been about the power of information to enable accountability and enable clinicians to beneficially alter their behaviour, allow us to improve systems. But in order to do this, we need to provide data that's timely, credible and relevant. And I think that is absolutely the crucial point. There is very little point in giving people information about what they were doing 6 months ago, because they will tell you that things have changed, or the ward was much heavier at the time, and what have you. How do we disseminate this information? Well, I think Neil has probably touched on some of these ways that we might do this around the West Midlands. I'm very interested in the fact that we can start to influence the way that opinion leaders behave. That's Tanya Pankhurst, who leads the development of the electronic healthcare record at UHB, and she's one of the first of the class of the going to the NHS Digital Academy and what have you, which seems far too like school to me for my liking, but so I'm rather relieved it's Tanya that's going, because there's actually rather a lot of homework involved. So I just wanted to give you that little perspective about the approach of our particular global digital exemplar to the development and of systems, the design of systems. Now that's a little bit unusual, because we are probably the only global digital exemplar with our own homegrown electronic healthcare record. But I think much more importantly to the wider healthcare economy is the way that you use the data to improve patient care. On the subject of working with the wider healthcare economy, I'm very interested. I think there's a strong argument in how GDs should act as enablers, not only for electronic implementations, but how we use the clinical information more widely, and how we share data across the healthcare economy. So those of you in primary care will know Zoo very well, and he's my new hero. Right? He has driven the introduction of the Your Care Connected system across primary care across Birmingham, Sandwell, West Birmingham, and Solihull CCGs. And what this does is allow access to the record, to the primary care record from secondary care. We're going to do the reverse eventually, but that's for another day. Masood's irrepressible optimism and drive never ceases to impress me. I think when he first came along with this, I thought, no, he's not going to do this, but he did. And along with obviously a lot of other people. But the important thing is this gives access to 1.7 million people's worth of data in a controlled fashion. So you have to have a legitimate relationship with the patient, and you actually have to have the patient with you and get their verbal consent, unless you undertake a break glass, if they're unconscious in A&E and what have you. I can't speak for all the other organisations, but we manage that quite carefully at the QE, where any break glass event is actually followed up with a letter with an email from Dr. Pankhurst, and I don't know how benign she looks, but she's not benign at all. for those of you who know her. She was my first trainee and is a fantastic person, but she's tough. At the moment, you can see on the left side, as you look at the slide, those are the secondary healthcare organisations that this has been implemented in. On the right side, those that it's going to be implemented in. So very much driven by Masood. The role of the Birmingham Global Digital Exemplar in this has been very much about providing technical expertise. This is UHB, as it were, as a small and medium enterprise, as a centre of software engineering. And the team at UHB have been great in terms of supporting Masood in that. I think also that this is a much more persuasive argument than the Land's End to John O'Groats argument that was used by Connecting for Health. That what happens if you're unconscious in John O'Groats and you're from Land's End and what have you. This local health economy question is much more relevant from my perspective. There is one issue around Your Care Connected which it wasn't designed to address, which is it is a view onto the primary care record. And I think that if we're going to go back to this developing, evaluating and promoting best practice, then actually we also need to be able to join up some of the data across the healthcare economy so that we can actually do at a macro level the kind of exercise that I showed you that we've done at a local level for VTE assessments at the QE. I'm going to show you a little bit of work. Again, this is thinking about our Global Digital Exemplar as much as a software house, as a centre of healthcare excellence. I'm going to talk to you a little bit about the work we've done for the 100,000 Genome Project. So here's the 100,000 Genome Project. It sets out to do what it says on the tin, to do whole genome sequencing on 100,000 genomes, so that's 70,000 patients and family members. The reason it's not 100,000 is because we're also sequencing the genomes, this somatic genome, from cancers from individuals. So if you've got a cancer, you're donating at least 2 genomes, as it were, and possibly more if you've got multiple metastases and what have you. The West Midlands really took a slightly different approach than perhaps other parts of the country. Those in the Fen, those around the Cotswolds, for example, who very much saw this as a research exercise. We saw this as a transformational exercise, an NHS transformational exercise. We saw it as an opportunity to start to work not just with UHB and Birmingham Women's and Birmingham Children's Hospital, who have undoubtedly been drivers of recruitment, and this is our recruitment in the first quarter, but to work across 18 local delivery partners, so secondary health care organisations across the West Midlands. And we've now recruited more than 10,000 individuals to 10,000 genomes to the 100,000 Genome Project. We're second only to Great Ormond Street. Strictly speaking, North Thames, but it's really Great Ormond Street in terms of recruitment. But in order to recruit that number of patients, we developed a system called Genie, which both manages the recruitment process and undertakes sample tracking, which is absolutely crucial in all of this, but also looks to link up the various, that's me fiddling around, looks to link up the 18 local delivery partners to collect their relevant clinical data for which they have consented. If we were to do that like a conventional intervention study, for example, to collect the levels of data that were being requested in the data models, would have cost tens of millions of pounds, in fact, quite possibly as in 50 million. 10,000 people, the level of data, hundreds of different data elements being requested. So not only was Genie designed to recruit and manage samples, it was designed to link up the electronic systems that sit across the local delivery partners. And this was developed by Steve Perks and his team at UHB, and is in fact being licensed, sold, as it were, both to Great Ormond Street to Royal Devon in Exeter, to Newcastle, and indeed we've now got several other organisations. So at the moment, Genie's been responsible for the recruitment of almost half of the recruits to the 100,000 Genie project. So I think 27,000 out of 56,000, something like that. And we're undertaking a similar process, certainly in the North Thames, of trying to connect electronic systems, link them, normalise the data, and return it to the 100,000 Genome project. I'll just quickly give you an example. I've got Pankaj at the back, so he'll be very happy because Pankaj has been one of the leaders of this particular project. We are interested in collecting imaging data, not just the report, but actually the images for particularly cancer, but it is also relevant for rare disease, so radiological imaging. And so we were funded by NHS England to implement a regional image sharing platform. At the moment, secondary healthcare organisations, as you probably know, share images largely using an image exchange portal, which is a push. So those organisations that acquire the images then push the image to those who require them. That's done for emergency referrals, it's done for MDTs and what have you. The regional image sharing platform is a pull, so you can discover, and so for those consented patients, we can automatically, based on 3-point identification, including their NHS number, pull in their image files from across the region without ever having to go anywhere near individual tax managers and what have you. Clearly we have to go to them to actually do the original implementation, but that's small data compared to 10,000 recruits. I think that the other nice thing about this is that it has a secondary benefit, which is that it is also available for clinical care. So if you are one of our neurosurgeons in Birmingham, for example, and remember it's currently being rolled out, disseminated across the region, and the CT scan of somebody in another hospital hasn't actually come across, you can actually go and pull it down because you have a legitimate relationship with that patient. That referral has been made to you. Or if you're sitting in a cancer MDT and the images aren't there for you to review that week, then again, because there has been an oversight, an IEP or what have you, you can go and discover those and actually get the MDT to consider that patient there and then and not be having to wait till the next MDT, which is usually a week later. So I think that for me is an ideal example of transformation, of actually making the NHS work better, but also using it to improve quality and to drive research as well. So that in addition to just getting the report, we get the image, 2 centimetre lesion in the right hepatic lobe, which some of you will be able to see. So, right, my mouse isn't working very well, which is over there. But more importantly, thinking in terms of research, we can actually download the original files, and you can't move on Radio 4 for artificial intelligence at the moment. So this comes out of John Bell's life science strategy. AI is all over that, and every other morning, probably on the Today programme, there's some mention of AI. In the future, across the West Midlands, there is likely, there is almost signed off, or maybe even signed off, a project to start to digitalise histology, so that we'll be able to do the same for histology, and of course, we actually have the whole genome sequence. We don't share that because it's 200 gigabytes per person, so that's a lot of storage, so that's all centralised. So clearly, a whole genome sequence, strictly speaking, is patient identifiable. It is pretty unique to you, so there's a lot of security around that. But what we are sharing are specific mutations, so you've got a PI3 kinase mutation associated with a particular lung cancer, for example. So I guess that then turns to, well, where do we get best cancer care, for example? Well, if possibly the Memorial Sloan Kettering, 1,000 physicians, treats more than 600,000 patients a year, 400 different types of cancer, maybe. Maybe it's the milestone, what have you. But if you actually just look at Sloan Kettering actually is a very major research institution and hospital in New York, but it actually has arms across Long Island, New Jersey, and elsewhere in New York. So it's a network as well. And my take on where we may go from the 100,000 Genome Project is to really use electronic systems as a key enabler to allow us to achieve critical mass in terms of delivering some of the healthcare that we are interested in with high levels of quality. So reaching critical numbers around by achieving regional tumour boards or sub-regional tumour boards, depending on the size or the numbers that you're getting through. So we actually achieve the kind of numbers that one sees attending Sloan Kettering, for example, or the MD Anderson, or what have you. And I think to deliver the best possible healthcare to the population of the West Midlands, we need to be thinking not big, but kind of medium. Yeah? West Midlands, 5 million, 5 or 6 million probably, and that's the kind of population that we need to aggregate in order to generate the best possible outcomes by having a critical mass across increasingly specialised care delivery. So those are the cancer pathways currently open in the 100,000 Genome Project, just to give you an example. And I don't think this just applies to cancer. I think it applies in all sorts of settings. My colleague Will Bradlow is working on aggregating information within UHB and integrating information around hypertrophic cardiomyopathy. But he's also working with many colleagues across the region to bring information together. And clearly for hypertrophic cardiomyopathy, that's absolutely crucial, because these things run in families and cause sudden death, and you don't always know. David Frost, for example, being and his family being one good example. You don't always know when that your father has died in the Brompton of hypertrophic cardiomyopathy, and his son died of sudden death, I think, in the States. And that family's become real drivers towards actually starting to make sure that we share information at a regional and indeed a national level. So just to wrap up, I think if we're going to discuss developing, evaluating, promoting and delivering best practice, we need to have a dialogue across the West Midlands, and I think the AHSM in particular plays a very important role in this, because size matters and connectivity matters, and that comes back to the points that Neil, I think, would have made this morning around the digital ambassadors and what have you. We need not just to do this at a local level, we need to do this at a regional level, and I think a region is a sweet spot in terms of the discussion that we have with the public and with patients. We're not talking about sharing information for best care with somebody in the south of London. We're talking about sharing it across the region that you're likely to have some contact with, or members of your family are likely to have some contact with. And I think that by sharing information, we drive best care, but that can then drive quality improvement and indeed research. And if you think about it, the National Genomic Tender is out currently. There are likely to be 7 genomic hub laboratories. So the whole of the genomic testing is going to be happening at a population level of probably between 5 and 10 million. So that's a sweet spot in thinking about what is it that we're actually delivering to a population that's meaningful and shareable. I think we also need to engage with professionals. Medics, certainly, they've got MD, CCIO, but crucially CEOs, CCOs, CIOs, because this is about connecting systems and for everyone buying into the idea that actually connectivity is a good idea. And Pankaj can talk he won't talk, I know, but he could talk to actually the differences in attitudes that he meets across different departments. And I completely understand that. We're all under a lot of pressure, and this feels like, in the setting of the 100,000 Genome Project, it's something special. I think we've got to get over ourselves, get over this. It's not something special. This is how you deliver high quality care and improve care. Just a final, well, last but one slide, the resources that we have in the West Midlands. I've left West Midlands Ambulance Service off there, but shouldn't have done. But include expertise within the global digital exemplars. We were recently, just 10 days ago, 2 weeks ago, awarded a Health Data Research UK centre based in Birmingham, but across the Midlands, so Birmingham, Warwick, Nottingham, Leicester, and I think that's a fantastic federation. So that's one of 6 Health Data Research UK centres. London, Oxford, Cambridge, predictably, Scotland, Wales and Northern Ireland, and so effectively the Midlands HDR UK Centre is the provincial, as it were, centre, which is, these centres are essentially successors to the FAR Institute. And I'm very keen that the HDR UK Centre in the Midlands is very much centred on making it work within the NHS. This isn't purely an academic exercise. And indeed, UHB is the only non-university partner within the HDR UK setup. So how do we actually do what I just described to you, not just as an academic exercise, but as a real quality improvement and quality assurance exercise? Coming down the track then, we've got the local health and care record and digital innovation hubs, and I think that puts the Midlands and the West Midlands in particular in a very good position. These centres put the West Midlands in a good position to start to bid for these. I think that the digital innovation hubs, which are essentially safe havens for data to be linked for the purposes of research, are a good idea, but unless you are ensuring that the data that you are submitting are being used clinically and the linkage is clinically relevant in the ways that I've described, then there are significant issues around, well, what is the quality of the data? So for me, it's about making it usable at the front line and secondarily using it for research. So thank you very much for your attention and congratulations for getting here and good luck getting home. Thanks very much.
Thank you very much. And to give an insight, not just strategically what the Global Digital Example is doing, but some real examples of the difference that's being made to clinicians and to the healthcare interaction. It's worth observing, someone mentioned the digital health ambassadors. The technology challenge around getting Genie across 18 different organisations was huge. But whilst it was developed by people, it also had to be implemented by people. And what we did in partnership with the Genomics Medicine Centre at UHB was, as an HSM, we invested in 3 genomics ambassadors. And their role was sometimes hand-holding, sometimes introducing and brokering relationships, reassuring and advising and signposting people to information. And I have never, 20 years in the NHS with a lot of responsibility for trying to roll out major technological implementations, to see an integration across 18 different organisations in about a year is just not something that anybody would have believed. And the technology behind it was critical, but as was the winning over the hearts and minds and reassuring the clinicians and the technologists and the patients that this was all going to work. The learning that we had from the genomics ambassadors has been quite central in bringing about our digital health ambassadors to try and play some of their role. So thanks very much.
They map directly onto one another. I know, we need somebody like that.
So we'll see what beautiful things happen when genomics ambassadors and digital health ambassadors get together. I'm sure lots of Ferrero Rocher goals and methods. So I'm conscious I said I'd try and get away for half past, but while we've got Simon here, would you have time for a question?
Yes.
If people have questions? Well, thank you very much indeed for your time, Simon, and that was really useful. Thank you. So I'm just going to wrap up. I'm not going to summarise what's come out the tables. We're going to be taking all of that in, capturing it, and we'll be sharing that back out with you. We will also be sharing the presentations. We will probably post them somewhere and send you a link so you can download the slide decks. The first thing I want to do is thank you sincerely once again. When you've got something like this in the diary, you know that the boss knows you're out at a conference, so you don't have to go to the office or the ward. And then the weather's really bad, and the temptation to say, do I really want to travel all the way to Birmingham? You did. I hope you've got some value from it. I can tell you without a doubt, we as an academic health science network have had a huge amount of value from the input from all of the different perspectives. And I hope that will be reflected back through your participation in our digital health learning community, the Global Digital Exemplars Network, and Health 2.0. And please do contact us. There's business cards on the table if you just want to send a personal email to me or Randy or Ellen, who you can contact through us. Do please get in touch. Let us know how you want to engage. Ask for things if we've not described them as an offer that we do as an HSN. As long as it's not writing cheques for you, we will always try and accommodate. So have a very safe journey home. Can I just thank Joe and Vanessa for doing the organisation behind today, which we recommend. And to Ripple who have done the videoing, and if they can make me look good, there's some extra bonus. Can I also, I don't usually do this, but I'd like to thank Chris, our AV guy, who at 20 minutes notice managed to set up a video link through to Windsor and get the NHS England CIO presenting on our screen here. So thanks very much, Chris. Really appreciate it. Have a safe journey, and see you again soon. Thank you.